Good afternoon. I would like to thank the organizing committee for participating in this course. And now we are talking about screening for diabetic foot at risk for ulceration and infection. Uncontrolled diabetes contributes to development of neuropathy and peripheral arterial disease by complex metabolic pathways. Loss of sensation caused by peripheral neuropathy, ischemia due to peripheral arterial disease, or a combination of these, may lead to foot ulcers. The purpose of this conference is to review the screening for diabetic foot in order to determine a risk level for that foot, and thus be able to establish the most appropriate follow-up for treatment. First, examine the feet. Look for lesions such as fungal infection. Did you see the screen, the mark? Okay.
Yes.
Okay. Cracks and skin fissures, deformed nails, macerated wet space, calluses, or deformities such as hammer toes, claw toes, and pescadus, which increase the risk of ulceration. Feel the temperature of the feet with the dorsum of your hand. Cold foot may suggest ischemia, and increased warmth with redness that the smell it makes suggests inflammation such as acute charcot foot or cellulitis. Active signs like ulceration, rest pain, gangrene, or cellulitis. Second, symptoms in case of peripheral neuropathy, symptoms vary according to the type of sensory fibers involved. The most common early symptoms are induced by the involvement of small fibers and include pain and unpleasant sensation of burning and tingle. The envelopment of large fibers may cause numbness and loss of protective sensation. LOPS indicates for present the distal sensory motor polyneuropathy and is a risk factor for diabetic foot ulceration. The following clinical tests may be used to assess small and large fiber function and protective sensation. A small fiber function with the pinprick, okay, and a rod to measure the temperature. Large fiber function with the tanning fork and the monofilament, and protective sensation with a monofilament. Nerve check is a portable QST device that measures the vibration called warm perception threshold and the head pain threshold of the patient. It uses the method of levels where a series of period stimuli are played over the broad range of intensities to produce a categorical output and define the severity of neuropathy. This is the tested light touch. We tested with the same Weinstein 5.07 monofilament. The filament should be applied perpendicular to the skin surface of the sole with sufficient force so that it buckles, like this. The places to application are not universally agreed. Most studies recommended testing at 10 sites, but most purpose that the sites of examination should be on the plantar surface of the first, third, fifth metatarsal and the first toe, bilaterally. Areas of ulceration, calluses, scars, or necrotic tissues should always be avoided. The patient is asked to say whether he can feel the pressure applied, yes or not, and in which place. The sensation of pressure using the buckling monofilament should first be demonstrated on the patient on a proximal place, like upper arm. A normal protective sensation of pressure is considered to be present when the test is correct on at least 2 out of the 4 places on each foot, and there should be at least 1 sham application per place. When we test superficial pain, a disposable pin should be applied just proximal to the toenail, like here, on the dorsal surface of the hallux, with just enough pressure to deform the skin. The pin can have a sharp or a dull edge, and the patient is asked to recognize if the sharp or the dull edge is touching him and at what place. An inability to perceive the pinprick correctly over either hallux is regarded as an abnormal test result. The pinprick should be performed starting from the toe and advancing toward the knee and the anterior surface of the both legs. Patient should not be allowed to look during the examination. Documentation about the level at which the sensation goes from dull to sharp is made for both sides. Vibration perception is tested on the dorsal side of the distal phalanx on the great toes, just proximal to the nail bed. It can also be tested at the medial malleus. The tuning fork should be placed perpendicular to the foot at a constant pressure with the patient eye closed. The examination is repeated twice, and there should be at least one sham application in which the tuning fork is not vibrating. The patient is asked to report his perception of both the start and the end of the vibration, and a normal response is defined when the patient loses the vibration sensation, but the examiner still perceives it while holding the fork on the tip of the toe, or the patient still feels the instrument vibrating while the examiner has stopped it by touching its edge. Normal sensation is considered to be present when the patient is correct on 2 or 3 tests. The vibration perception threshold is tested by the tip of the big toes using the biotensiometer. The patient is asked to identify when the vibration starts while the voltage of the instrument gradually increases. Is it usually carried out 3 times in each side, and the minimum volume is calculated. A value of 25 volts is usually considered abnormal. The ankle reflexes are the first to be avoided, either reduced or absent, in diabetic neuropathy. Normally, it's difficult to assess, and therefore the responses are usually classified as present, present with reinforcement, or absent. While the patellar reflexes is evaluated, are tested, the patient is asked to hook together the flex fingers and both hands and pull. We examine the perception of temperature differences using a rod with 2 different edges, one metal, cold, and another plastic, warm. The examination places are similar for those for pain. Third, as for the history of intermittent claudication and rest pain, which suggests peripheral arterial disease, palpate the posterior tibial artery and dorsal pedis artery in both feet and record pulsation as absent or present. You can use a Doppler device too. The ankle brachial index is an action measure to diagnose peripheral arterial disease. Is it the ratios of highest systole blood pressure at the ankle to the diastolic pressure at the arm, and is measured using a Doppler device. Consider referral to the vascular peripheral, especially, in that case, moderate, severe, and poorly. Remember, absent presses, calf claudication, absence of hair in the feet, altered temperature and thin, bluish skin are suggestions of peripheral arterial disease. A bounding, easily directed pulse in a warm, dry foot is suggestive of anatomic neuropathy, which causes abnormal arterial venous shunting. These tests not only screen for the presence of diagnosis, but also predict future risk of complication. The literature shows different classifications, stratifications, degrees. In the Diabetic Foot Service of the Podiatric Hospital of the University of Barcelona, this is the risk stratification tablet used. Is it an adaptation of the International Working Group on the Diabetic Foot and AS NICE? So thank you very much for your attention.